Hi, good morning. Welcome to Grand Rounds. Feeling more and more like spring and looking more and more like spring. I think many of you know I'm up pretty early, and it's always fun when the days get long enough that when I get up, it's already light out. So all of you know I have a deep-seated interest in adult survivors of congenital diseases. And I don't know if I've ever mentioned to you, but most of my Hermansky-Pudlak syndrome patients over the 20 or so years I've cared for them have been adults. I've cared for kids too, but it's largely been an adult population. And one of the challenges for us in internal medicine is how do we support patients as their disease processes manifest over years and decades. We're used to thinking about complications of diabetes and complications of heart disease, but also complications of congenital disorders or complications of pediatric diseases. There's many more patients who are survivors of acute lymphoblastic leukemia than there are new incident cases in a given year. There are many more patients who are survivors of congenital heart disease than there are incident cases of congenital heart disease. And in fact, there are more adults with congenital than there are kids. And so in that context, we're really delighted to have Barry Love with us today, who's an assistant professor of pediatrics at the Icahn School of Medicine at Mount Sinai, and also an assistant professor in the Department of Medicine at the Icahn School. He's also director of the Congenital Cardiac, thank you so much. I lost that for a minute. As well as the EP lab as well, he's the director. And over the course of his year has focused on how to manage patients with congenital heart disease. He completed his undergraduate degree at the University of Toronto and then his medical degree at the University of Western Ontario in London, Ontario, followed by his residency in pediatrics at McGill, and then his training, which was quite extensive at Boston Children's and the Harvard Medical System, where he completed first a fellowship in cardiology and also one in catheterization and one in EP. It's really delightful to know there are people like Dr. Love in our midst who can help us support patients with congenital heart disease. And I was mentioning to him, I just covered a day on service on the PINC team a couple of weeks ago, and we had a patient present to us who'd only recently been diagnosed with an ASD, and she was in her 40s. And so we're really happy. It's one of these ones where we're so happy to live in a tertiary and quaternary medical world. We have such expertise in our midst. And with that, thank you for being here and welcome.
Thanks so much for that kind introduction. So what I'm going to talk about, we'll jump in. We're going to review some of the adult congenital heart disease demographics and epidemiology. We'll discuss some of the more commonly encountered problems in ACHD, and again, just some case examples. And we'll show, just show an example of how our congenital catheterization techniques can be extended to adults with structural heart disease. So as we were alluding to, congenital heart disease is common. About 0.8% of all live births have some form of congenital heart disease. But moderate to severe congenital heart disease is less common, about 3 to 4 per thousand. And the incidence has been fairly uniform from the 50s to the present day and across ethnicities and countries of origin. As it turns out, the incidence of serious congenital heart disease, however, is actually going down a little bit in the Western world, and that's due to prenatal diagnosis and termination of some of these pregnancies. So depending where you are in your belief system and such, this has been an option for people recently as well. It's been 81 years since the first procedure to treat congenital heart disease, which was ligation of a patent ductus arteriosus in 1938 at Boston Children's by Dr. Gross. And over the past decades, there's been exponentially better survival for children born with heart disease. And in the US, there's now estimated to be 1.3 million adult patients with congenital heart disease. So this slide shows you the improvement in survival with congenital heart disease, again, with a decreasing mortality. This is actually an interesting slide from a paper published by Paul Carey in JACC of 2010. And what it shows is, if you look here, the year 87 to 88, this is the age of death of patients with congenital heart disease. And as you can see, neonatal deaths comprised a lot. And as you get older, again, during childhood, it's not as many. In middle age, it's not as many. And then as you get older, there's this bulge. Moving forward to the year 2004 to 2005, we've had a really significant decrease in our incidence of neonatal deaths due to improvements in surgical techniques and other neonatal care that we're able to provide for many of these patients with serious congenital heart disease. And our mortality has decreased certainly in childhood as well. And that bulge is now moving out, and the age at which patients die is moving out as well. So this is just showing you some of the changing epidemiology. Again, as was alluded to earlier as well, in 1965, there were more pediatric patients than adult patients with heart disease. By 85, it was 50-50, and by 2005, the curve had shifted such that there are more adult patients now alive than children with congenital heart disease. So a good question is who's going to look after these patients? So it was very interesting. The ABIM gets requests all the time for new subspecialty certification, and basically they had said a few years ago, like, we're done. That's enough. We're not creating any more. But actually, the case was made for subspecialty training and certification in adult congenital heart disease, and most of the push actually came from the patient organization, the ACHA, the Adult Congenital Heart Disease Association, which was this group of patients that, again, is becoming very vocal in terms of pushing for recognition that this really is its own subspecialty. And it was recognized by the ABIM that really adult cardiology really wasn't a good place for these patients to be looked after, that there's just not the expertise there. And pediatric cardiology, again, similarly, a lot of these issues that are coming up weren't properly cared for by pediatrics, and there was a recognition that there really was a need for a specialty and a group of people to actually look after these patients. And so in 2012, they announced a new subspecialty program. And the way that it works is that it's a 2-year subspecialty training after you can either complete adult cardiology 3 years or pediatric cardiology 3 years. And then it's a 2-year subspecialty program for subspecialty training. And after that, there's a written examination. For the first 3 cycles, if you can show that you spend more than half your time doing adult congenital heart disease, you can write the exam and be grandfathered in. And I did that in the first cycle. Coming up in the next few months is the last set of those exams, and then the only way that you'll be able to achieve subspecialty certification in adult congenital heart disease is by doing the subspecialty fellowship. So we're training more and more people, but again, there's still a lot of these patients out there for the number of subspecialty people who are experienced looking after them. In terms of the patients, there's a bunch of different ways to look at it, but the way that I sort of think about it is 3 basic groups. There's a silent form of congenital heart disease that's basically first recognized in adulthood. So somebody who didn't recognize that they had a problem, for instance, an atrial septal defect that was first diagnosed in the 40s. That would be something that I'd be referring to. And then there's the second group of patients, congenital heart disease that was recognized in childhood, but they didn't have any intervention. They didn't require intervention, or it was too complex, or the wrong geographic location, patient parent preference, et cetera. Excuse me. And then there's the third group of patients, this growing group of patients that was recognized and treated in childhood, and now they've grown up and they're adults, and they either had a complete repair, or again, one of the patient groups that we find more and more difficult are patients that had palliations and now are adults with those palliations. And what I really like about congenital heart disease, adult congenital heart disease, that I find so interesting is that really you get the whole history of congenital heart disease shown to you in one patient, because the surgery that they may have had 40 or 50 years ago is not what we would do now. And what's really interesting is that you get to be a bit of a detective in terms of, the patient will come in telling you one thing, or they'll have, carried through their record, something, and you'll look at it and you'll say, that doesn't make any sense. So for instance, I had a patient just recently who was referred to me from St. Luke's, who came with the diagnosis of having had a VSD repair when he was a child, and he came with pulmonary regurgitation. So those things didn't really fit. And he was in his 50s, and he said that he had had surgery in Israel, which would have been in the late 1960s, something like that. So I can tell you that the first open heart operation that was ever done, the first cardiopulmonary bypass operation that was ever done, was in 1954. And so we did not do neonatal repairs in patients in 1960, and certainly not in Israel in 1960. That just didn't happen. So I can already tell you that this patient did not have an open heart VSD closure in 1960. So although this is being parroted through the chart, I know that that didn't happen. And in fact, with pulmonary regurgitation, everything that he had, and he had an open sternotomy, what I presume that he must have had was pulmonary valve dilation under inflow occlusion. So this was a procedure where, again, before you did cardiopulmonary bypass, if you had narrowing of the pulmonary valve, what they could do is open the chest, they hyperventilated the patient, you snared the IVC and the SVC, so now you have a bloodless field on the right side. They've got no cardiac output for the time that you do that. And you've got a couple minutes to open up the pulmonary artery, put a dilator in, open up the valve, close the pulmonary artery. You got about 2-3 minutes to do that, and then you release the clamps on the SVC and the IVC, and the circulation returns. Ingrid Hollinger, who's one of our older anesthesiologists, still remembers them doing these inflow occlusion procedures. That predates me, but in any case, I'm certain that that's what this patient must have had. In any case, he had pulmonary regurgitation, needed a surgical pulmonary valve replacement. But in any case, it just shows an example of how you sort of have to be a detective when you see these patients and kind of figure things out based on what you know to be the history of the patient and the history of how we used to do things. So some of the challenges of care in adult congenital heart disease, one is underappreciation of congenital heart disease in the medical community. Many adults with congenital heart disease are lost to follow-up. They may lose, they have new adult independence to start with. So, you know, they want to sort of act as adults and sort of do what they want, and not going to doctors is one of those things that they like to do. They may lose insurance as adults, and that was a huge issue. Certainly before Obamacare, it was a major issue. Now it's been a little bit better since then, but certainly that was a major issue. They may move to a different location, and when they re-present with congenital heart disease, they often don't know much about their disease. I had a patient with transposition of the great arteries who had a mustard procedure, and he was an engineer, a PhD in engineering. And he came to us, and he could not articulate his disease at all. He had no idea what was done to him. And it's just interesting, right? Here's somebody who clearly is a very smart, educated person, and he's got no idea what happened to him. And it's interesting that things tend to get compartmentalized in families. As it turns out, most of the time it's the mother who's taking the child to the appointments and such, and is the one who's really up on these things. And the child may not be participating in their care. And as they get older, they may still not be participating much in their care and just not take an interest in it. And that happens to a large degree in families for lots of other things. My wife will tell me what to buy at the grocery store because I have no idea what we're missing in the fridge, right? That's not my business. I don't know what we're missing. So again, you know, things get compartmentalized in families. The problem, of course, is that as these children grow up and move away and aren't with their parent anymore, or their parent is debilitated or, God forbid, has passed away, they need to take responsibility for their care. And so there's been a big push in adult congenital heart disease to have a plan as children or teenagers to transition them to adult care and really educate them about their disease. And there's a lot of studies out there that show how these kinds of programs can help in terms of increasing the knowledge of patients about their disease. I used to think that we just did a really bad job, and this is a whole issue of transition. But as I look after more and more adults without congenital heart disease who also have, their other structural heart disease, they'll come in and, as they'll say, oh, what's your problem? Oh, I have a valve problem or whatever. And of course, that bypass or whatever it is. So it's not just isolated to congenital heart disease that patients don't know much about their disease. So I think we could all do a better job of helping patients know about these things. And there's a whole passport that we give patients with congenital heart disease that lists their diagnosis and a diagram of what they have and all these sorts of things. And this can really help in terms of when they go to different providers, helping them figure out what exactly is going on. As you know, it may be very difficult when patients have had operations to get old medical records. One of the biggest troubles has been the electronic medical record, because as you know, that was very expensive to go to. And what most hospitals, including ours, did is after they went to the electronic medical record, they basically let go all of their staff down in medical records. And so, they archived everything, but they might as well have thrown it out, because I don't know if you've ever tried to get an old paper record or something on microfilm. It's impossible now. It used to actually be somewhat reasonable. People could actually do it, but now it's almost impossible to get old medical records. Anything that predates the electronic medical record is almost gone. So the question is if we're looking after these patients, does adult congenital heart disease care make a difference? And so there was a paper published by the Quebec group out of McGill in 2014. So they have a very nice system in Quebec and in Montreal for looking at these patients. So what's interesting is that Quebec, there's not so much emigration from the province because of the language and everything else. Most patients in Quebec tend to stay in Quebec. And because of the nationalized healthcare system, they all the records end up going to one central place. And so not the medical records, but the diagnoses and these sorts of things are computerized, and they can actually track this over time. So they've got a pretty good idea about what happens to patients. And so they've been able to do a lot of statistics on this and look at this. So what they did is that there were guidelines that were presented in Canada for how adults with congenital heart disease should be cared for in 1996, and they were published in 98. And what they tried to show is that the attendance at adult congenital heart disease clinics mortality went down. Now, this is a nice graph, but I must say that again, there's a lot of things that probably contributed to this, and a lot of that had to do with the way that we changed surgical techniques and different things that we did with patients way back here that probably had a lot more to do with affecting mortality over here than did attendance at adult congenital heart disease clinics. I'm not saying it's not important, but I just don't want people to take too much credit, and just to say as well that you could also say that Princess Diana died in 97 and then Wayne Gretzky retired. That might have been also what contributed. So not necessarily, but it's certainly plausible. So what do patients have when they have adults with congenital heart disease? Like what's the most common diagnosis that you see? I get asked that a lot, and putting up this plot is very interesting. So this is from the CONCOR registry in Europe, and again, it's not to I don't mean for you to necessarily read all these things, but tetralogy, flow, coarctation, the aorta, VSD, transposition. So it goes on and on. But really, what this colorful plot graph shows you is what we deal with in congenital heart disease all the time. So each individual disease is individually rare, but collectively they're numerous. And this is what we deal with all the time. And it's interesting. I mean, this is what is always interesting, is that you come to work every day and you see a patient of, that with the flavor of a disease that you never necessarily seen before. And we see this really, this is what we see sort of all the time. It makes it interesting. It does make it very difficult to do research on these patients because the number of patients in any one silo ends up being relatively small. And so it becomes very difficult. A lot of patients, a lot of papers that get published, for instance, if you do a large multi-center study and you have 200 patients in congenital heart disease, that would be huge. That would be like groundbreaking in congenital heart disease, whereas 200 patients in a lipid trial, or using an ACE inhibitor or something, wouldn't even make it into the Journal of Reproducible Results in adult medicine, right? How many tens of thousands of patients did we need to enroll to show that ACE inhibitor improves outcome after myocardial infarction, or these sorts of things, right? You're talking about 10,000 patients to show a difference, and we just don't have those numbers. That wouldn't be that's not the whole population. That's more than the whole population of any one disease that we're looking at. So it makes it difficult to actually do research and show that we're making a benefit in some of these interventions that we do. So it becomes challenging. I'll just say that we looked at our visits from last year, and again, we had a similar scattergram of different diagnoses, however you want to look at it. So how old are these patients with these adults with congenital heart disease? So this was a study published by Gary Webb showing his data from Toronto when he was there, and also from the Mayo Clinic. And again, a big bulge in the 20s, but tapering out to the 70s. And this was back in 2001. We looked at our patients last year, and again, we had a similar bulge in the 20 to 30 year age group, but all the way out to even more than 70 years of age, we see adults with congenital heart disease. So how are these adults with congenital heart disease doing? So I find this graph to be really interesting. So this was published in 2015. So what this line here is if you're the average, I think this was a Norwegian population. So this is your average graph. If you're 40 years of age, what's your chance of dying in the next 5 years? So if you're 40 years of age, you're right at this point. So your chance of dying in the next 5 years is maybe 1%. If you're 50 years of age and you're on this graph, your chance of dying in the next 5 years is maybe 2%. If you're 60, 70, etc. By the time you're 80, the chance of dying in the next 5 years is almost 30%. So that's what this line is. Now, these plots for these different diagnoses are, if you're 40 years old with congenital heart disease, where do you fall on this line? So if you have an ASD, you're close to the baseline. If you have tetralogy of Fallot and you're 40 years of age, you're more like a 50-year-old who doesn't have congenital heart disease. You're more like a 50-year-old. Well, thank you. you're more like a 50-year-old. You've got a couple % chance of dying in the next 5 years. If you've got Epstein's, a little bit higher, systemic right ventricle, by the time you get to complex congenital heart disease, it's much higher. And if you have a Fontan, this is an operation that we do for patients that have a single ventricle. Basically, we can't put all the parts back together, and you're 40 years of age. You're more like a 75-year-old with the chance of dying in the next 5 years of about 15 to 20%. So again, it really brings out that there's a lot of diseases that we have here that we want to get these guys all the way down to this point over here. We have a lot of work to do. So what are the issues facing these patients? So arrhythmias is a big one. Atrial flutter is a big issue. So we call it atrial flutter, but we in our community we more refer to it as intra-atrial reentrant tachycardia. They've had many operations that typically involve the right atrium. They've got suture lines and scar and right atrial hypertension, and they tend to develop a lot of macroentrant circuits in the right atrium, and that's a big problem for us. They can certainly have ventricular tachycardia. There's risk of sudden death. They have heart failure issues. They may need transplantation, and there are reproductive issues. So I'm going to jump right in and start talking about some case examples of some commonly encountered problems, and we'll start talking about an example of atrial septal defect. So I'm going to put it out there, atrial septal defect in the adult. So blood flows from the left atrium to the right atrium across the ASD, and I'll put it out for those who haven't heard my talk. Why does blood flow from the left atrium to the right atrium in an atrial septal defect? Okay, so that's a common answer is that it's pressure difference. But let's do the mental experiment, and we're going to mentally excise the atrial septum here. So now what's the pressure difference between the left atrium and the right atrium? There isn't one, right? So, but blood still flows from the left to the right. So have we cured ASD? Obviously not. So there's another explanation. So I will show you with some aids here. So usually I use a red balloon and a blue balloon, but I didn't have any of those. So we're going to pretend that the green one, I guess we'll say, is the right ventricle, and the pink one is the left ventricle. So what I'm going to do is I'm going to make the right ventricle here more compliant. Just going to blow it up first a little bit. Sorry. Okay, so we're going to make this one more compliant. All right, now I'm going to put both in my mouth at the same time and blow. So remember, this is the right ventricle, and this is the left ventricle. I'll put them on the correct side here. Here we go. Right? So what happens? The one that's more compliant fills more than the one that's less compliant, right? So that's actually what's happening in the heart. So the reason why blood flows from the left atrium to the right atrium is because of the difference in diastolic compliances between the right ventricle and the left ventricle. So typically the right ventricle is more compliant than the left ventricle. And so if you've got a hole there, blood will flow from the left atrium to the right atrium. Now, because of the difference in diastolic compliances, if you have certainly an intact atrial septum, that will lead to a higher pressure on the left atrium than the right atrium. But the pressure is a result of the diastolic compliance. It's not the cause. And so if you make a hole between the septa, yes, there'll be a pressure gradient so long as the hole isn't too big. But what's actually causing that difference and what actually causes the flow is the difference in diastolic compliances. Now, in most of us, our right ventricle is more compliant than our left ventricle right from the get-go. You have a fair bit of flow. If you've got a fair hole and a fair bit of flow, you're going to see a fair, extra volume in the right ventricle. You're going to see more flow across the pulmonary artery. That's going to lead to a flow murmur. It's going to lead to wide split second heart sound and the pulmonic valve closing later. That's going to be diagnosed by a pediatrician as a murmur, sent to a pediatric cardiologist, and the patient's going to be treated in childhood for their atrial septal defect. But in some of us, the hole may not be quite as big, and the difference in diastolic compliances may not be as much, and you may not get that much of a difference in flow in childhood, and that patient may go undiagnosed to adulthood. Now, why do they present in adulthood? Well, don't forget, it's the difference in diastolic compliances. So what happens to the left ventricular diastolic compliance as you get older? It decreases, right? Our left side gets stiffer, and especially with hypertension and these sorts of things, the left ventricle can actually get quite stiff, and you get much more flow as you get older. And so I think this is a big reason why ASDs present first in adulthood, where they were never diagnosed before in childhood, is because you actually get more flow across the ASD as you get older, and then signs and symptoms as you get older. So we know that ASD closure before the age of 50 decreases the risk of atrial fibrillation. One of the problems here is that the volume that goes from the left atrium to the right atrium goes to the right ventricle, is seen by the pulmonary arteries, but comes back to the left atrium. So the left atrium is stretched, and that leads to fibrosis, scarring, and a setup for atrial fibrillation. We know that closure of the atrial septal defect at any age improves symptoms and decreases the risk of right heart failure. Elevated pulmonary artery pressure over time is usually not a contraindication to closure. So there's basically two groups of patients, two kinds of patients with atrial septal defect and pulmonary hypertension. So one is the really serious one. These are typically young women who are in their late teens or early 20s who've developed severe systemic level pulmonary artery pressure due to an atrial septal defect. And that's probably like a Venn diagram between primary pulmonary hypertension and atrial septal defect. So what it is they're probably predisposed to developing pulmonary hypertension. That excess flow triggers whatever the mechanisms are and whatever cascades there are, and leads to irreversible pulmonary vascular disease. And you can't close the ASD in those patients because at that point, their right ventricles would fail, and that you're going to have continuous progression of the pulmonary hypertension in those patients. So those are needed to close. Fortunately, that's rare. The other type of patient is the patient that sort of has chronic volume overload on the pulmonary arteries, and they develop slow, chronic increase in their pulmonary artery pressure. It's not so severe, and typically when you close the ASD and decrease the flow, the pressure also decreases in those patients. And so that's the majority of patients. And so typically elevated pulmonary artery pressure doesn't end up being a problem for most of our patients in terms of consideration of closure. And secondum atrial septal defect, which is sort of in the middle of the septum, is by far the most common type of ASD and can be closed percutaneously. So I'll show you how we do that. I'll give you a case example. This is a 27-year-old woman who presented with symptoms of shortness of breath since the birth of her first child 3 years ago. On examination, she has a systolic murmur. Her ECG is normal. I put that in because the books, they'll all tell you should have a complete right bundle branch block and these sorts of things. The thing is that, and as I'm sure you know, patients don't read the textbooks. And so, again, if physical examination and ECG and chest x-ray were sufficient to make the diagnoses in all these patients, like they tell you in the textbooks, we wouldn't have needed to develop techniques like echocardiography and these sorts of things to make these diagnoses. So it ends up being your physical examination skills and these other skills like ECG in terms of diagnosing structural heart disease. You end up being humbled by these things that, look, sure, you see certain patterns in many patients, but it's not perfect, and you just have to know how much to weigh these things in terms of making your diagnoses. So important, but again, just to keep in the back of your mind how much these things you necessarily have to weigh in terms of thinking about these patients. So in this patient had a transthoracic echocardiogram that showed a moderate secundum atrial septal defect with right ventricular dilatation and normal RV pressure and normal LV function. So we close ASDs in the cath lab under general anesthesia with TE guidance. We get femoral venous access only. We do right and left heart hemodynamics. We evaluate the ASD by TE. We balloon size it and we close it. And they typically go home the same day or the next day on aspirin. So this is what this patient looked like. Here's the left atrium, the right atrium, and you saw the flow going from left to right across the atrial septal defect. We put a balloon up and we make something that was oval, round. It doesn't dilate it, but we take it and we make it round so that we can measure it. And this patient measured 22 millimeters. This is what it looks like when we this particular device that we're using to close the hole. This is an Amplatzer Occluder that we put out the left atrial disc and the right atrial disc, and when we're happy to unscrew it and it stays in position. And that's what it looks like in the body here. We put out the left atrial disc, and we pull it back against the septum, and we put out the right atrial disc, and we push and pull, and when we're happy it's in good position, we release it, and that's what it looks like afterwards, a little UFO there. A little bit of flow within the discs, and that's how we do that. So pretty straightforward. The Amplatzer Septal Occluder that I just showed you was FDA approved in 2001. We can close defects between 4 and 38 millimeters with that. So as you get larger, the chance of being able to close it successfully ends up going down because there's lots of other issues in terms of making sure that that device sticks and doesn't interfere with other structures in the heart. The Gore Helix Occluder and then the subsequent generation, the Septal Occluder, was FDA approved in 2006. We can close defects up to 17 millimeters with that. And there's a new Gore Occluder that is in the next generation trials that we've been privileged to be one of 20 US centers evaluating. And this can close defects between 8 and 35 millimeters. And this is a nice device and gives us some more options in terms of some of the things that we can do. So we can close almost all of the secundum atrial septal defects in 2019 with the cadre of devices that we have. So who's an appropriate candidate for ASD closure? So patients who have evidence of atrial septal defect by transthoracic echo with a dilated right ventricle. Additional tests may depend on the transthoracic windows. We may get a TEE. If we think that we have enough information from the transthoracic echo, though, we may go straight to the cath lab. And MRI can help you look at the QPQS and define the pulmonary venous anatomy if there's a question from that standpoint. I'm going to move on and talk about a cousin of atrial septal defect, which is patent foramen ovale. It's similar, but very different. Unfortunately, it has the same ICD-10 code and ICD-9 code, and so it's been a real problem in terms of looking at some of these things. But patent foramen ovale. So as you know, there's an association between cryptogenic stroke and patent foramen ovale, especially in adults less than 60 years of age. And the mechanism of stroke is postulated to be paradoxical embolism of venous thrombus through the PFO to the cerebral circulation. And it's reasoned that PFO closure should decrease the recurrent stroke risk in those who've had a first event, so-called secondary prevention. So again, the foramen ovale it's a flat valve, right? So we're all born with this. It serves to direct the umbilical venous blood that's got the most oxygen nutrient-rich blood across the atrial septum to the left atrium, left ventricle into the head before we're born. When we take our first breaths, the blood and the umbilical cord is clamped, the blood returns to the left atrium through the lungs, closes the PFO, and in most of us seals shut. But in a good proportion of patients, maybe 30% or so, it still stays as a potential trap valve, flat valve or trap door, and in most of us is of no consequence whatsoever. But in patients who've had stroke for no good reason, we find the PFO more often than we would find in the general population, at least 50% of the time, and this is where this issue comes. And so the question is in patients with young patients with cryptogenic stroke, so 18 to 60 years of age is typically in whom we've studied this. If you've had a cryptogenic stroke and you find a PFO, what should we do about it? What's the best way to keep them from having another stroke? So first of all, the recurrence risk seems to be on the order of about 1 to 2% per year. How can we best keep these patients from having another stroke, especially if they're young? So the best way to do this is a randomized trial, right? You take patients like that and you randomize them. Either you treat them with medical therapy, so antiplatelet or anticoagulation, or we've got device closure now where you can close the PFO and treat them with antiplatelet agents typically, and then you see how they do. So the first trial to do that was Closure 1. It was the first randomized controlled trial using this old generation flex device for recurrent stroke or TIA, and patients were randomized between 2003 and 2008, about almost 1,000 patients. And the preliminary results were announced in 2010. And basically what that showed is that there were fewer events in the closure group than in the medical arm, but it wasn't statistically significant. And there were a lot of criticisms of this trial. One is that the high-risk patients weren't being included. Those patients were just getting device closure off-label. Wasn't the greatest trial, but the biggest criticism is that the strokes that happened in many of these patients weren't really cryptogenic. A lot of them were what are called lacunar strokes, which are deep strokes that have to do with small vessel disease, and whether the patient has a PFO or not, you're not going to affect their recurrent stroke risk by closing the PFO if they've got small vessel disease that's causing their strokes. So that was a big issue. And so the second randomized trial to look at this was called the RESPECT trial. And this study was probably most important. It used a different device, but most important is that it excluded lacunar strokes. This study also included only recurrent stroke, not TIA, because again, TIA was a bit of a soft point in terms of trying to figure this out. So the results of this trial were announced in 2012, and the average follow-up was 2.6 years. So again, almost 1,000 patients enrolled, randomizing into device closure versus medical therapy, and it was powered until there were 25 events. And this is what the intention to treat analysis looked like when it was announced. So there were 9 events in the device group and 16 in the medical arm, because it was powered to 25 events. But this gave you a p-value of 0.08. So there were fewer strokes in the device group, but it wasn't statistically significant. So I'm just going to put it out there while I have a sip of water. What does a p-value of 0.08 mean? Right. So what that means is there is a difference, right? There's half the number of patients had an event in the device group compared to the medical arm. But a p-value of 0.08 tells you that statistically that has an 8% chance of happening just by chance alone. And so we normally say, okay, if it's a 5% or less chance of happening, that's a positive trial. But 8%, it's negative. Again, it's just important to remember what these things mean, right? So what's interesting is, again, when you're dealing with small numbers of events, and again, it becomes a difficult problem, small differences make a huge thing. So what's interesting is that 3 of 9 events that happened in the device group, a patient didn't even have a device at the time of the endpoint of stroke. So one patient, for instance, was randomized to device closure and then decided, got cold feet, did not want to have device closure, ended up having a subsequent event, but got analyzed in the device group in terms of the intention to treat. There was another patient who was randomized to device, and then ended up being found to have coronary artery disease, had a surgical cabbage and PFO closure surgically, had a perioperative stroke, but was analyzed in the device group. So these are some of the problems that happen. Now you can say, okay, but intention to treat analysis is supposed to get rid of it. So it's true, when you've got thousands of patients in each group, intention to treat analysis, those things will come out in the wash. But when you've got only 25 patients, those small differences can make a huge difference. And this was a big argument in terms of how to interpret this data. We're trying to get at the truth. We're not trying to stand on a pedestal here and be statistical fortresses in terms of how one thinks about randomized controlled trials. In any case, these patients continue to be followed, and at an average follow-up of 5.9 years, those curves continue to separate, and you still had an almost 50% risk reduction with a p-value that was less than 0.05 with an average follow-up of 5.9 years. And so at that point, the FDA then agreed that this therapy was beneficial, and the Amplatzer PFO Occluder was approved for the indication of PFO closure back in October of 2016. And then in September of 2017, that trial, the RESPECT trial, was published along with another trial, the REDUCE trial, that again was similar with using the Gore occluder that was also positive, and a closed trial, which was a French trial that used a sort of a smattering of devices. And all those 3 trials were positive in terms of showing a benefit and fewer events in device closure patients compared to medically treated patients for the prevention of recurrent stroke in patients who have already suffered 1 stroke. So what do we know from these 3 positive PFO trials? So PFO closure plus antiplatelet therapy seems to be superior to antiplatelet therapy alone for the prevention of recurrent cryptogenic stroke in the setting of PFO, especially with a significant shunt or atrial septal aneurysm. So that's a very floppy septum. All the patients that were studied in these trials were all between 16 and 60 years of age, and the benefit appears to lower the baseline risk from about 1% per year to about 0.5% per year. But this is one of the most important things, is that excluding other causes of stroke is important to maximize the benefit from PFO closure. There's a signal for increased risk of atrial fibrillation with the Gore occluders, but that's mostly peri-procedural and goes away. So it's not like these patients have atrial fibrillation and now we've caused another problem for them in the long run. And procedural complications are low. So I'll show you a typical case example of somebody who we look after. This is a 47-year-old who presented with symptoms of left-sided weakness and aphasia. Her symptoms improved after 20 minutes. Her MRI showed evidence of stroke in the right MCA territory. Her other workup, including carotid Doppler, head MRA, ECG, hypercoagulable workup was negative. She's a non-smoker, not on oral contraceptives, and a PFO, TE showed a PFO with this atrial septal aneurysm and a positive bubble study. She interestingly has a history of migraines, which is actually pretty common in these patients. She was started on Plavix, she's aspirin allergic. So these we usually do just with a bit of sedation or no sedation and just local anesthesia. We get femoral venous access for 2 catheters, and 1 we use intracardiac echo for. We don't do hemodynamics, we evaluate the PFO, we close it, and they typically go home the same day. This is what the intracardiac echo probe looks like. It's an 8 French probe, and these are the images that we get. So it's pretty similar to TEE, except the thing closest to the probe is the right atrium, and this is the left atrium, because now the right atrium is the thing that's closest to the probe. So here you can see septum, what's called septum primum. This is septum secundum, and you can see it really bouncing around there. This is this atrial septal aneurysm, how it bounces around. And when we inject bubbles, you can see the bubble wash coming across the foramen ovale to the left atrium. So we go ahead and put in a PFO occluder, very similar to how we deliver the ASD occluder, and then a negative bubble study afterwards. So that's how we deal with PFO. And so we've been doing more and more of these, again, making sure though that we're trying to keep it to the right patients, because about 1/3 of people out there will have PFO. And so there's a lot of patients out there who think their symptoms may be related to PFO, and in fact, they're not. So really patients who have had a stroke are the patients that are appropriate and whom we should close. And there's really no indication for primary closure of PFO in somebody who's never had stroke. I'm going to talk briefly about ventricular septal defect, and the reason why I'm going to talk about it briefly is it's mostly a disease that we have to deal with in childhood. So the prevalence is about 1 to 5 to 3.5 per thousand live births, and the incidence decreases sharply to adulthood. There's spontaneous closure of many or most VSDs. So we close VSDs in childhood for if they're significant. So if they've got elevated pulmonary artery pressure, if they've got a big VSD, you have to close that VSD by the time they're a year of age, because if not, they will develop irreversible pulmonary vascular disease, so-called Eisenmenger syndrome. So that has to be closed in, before they're a year of life. If they have high flow, so more than 2 to 1, it's going to put a chronic load on the left atrium and left ventricle, leading to chronic stretch, diastolic dysfunction, atrial fibrillation. So we close those by the time the child is about 3 or 4. If they still have a QPQS of more than 2 to 1, we'll close the VSD for that reason. There's a rare patient that gets progressive aortic insufficiency, or in certain anatomies that are at risk for progressive aortic insufficiency, so we'll close those patients as well surgically. The bottom line is that I often get calls from people telling me, oh, I've got a patient with a VSD and they've been followed for a long time and they're 40 years of age, and I think their pulmonary artery pressure is going up. What's interesting is that doesn't happen. So unlike atrial septal defect, and I don't know why the pulmonary arterial bed should know the difference, but if you've got a QPQS of 1.5 to 1, so 1.50% extra flow to the lungs with a VSD, you don't develop increased pulmonary artery pressure over time, which is sort of interesting, and you don't develop right ventricular dilatation. So if you didn't need to get it closed in childhood, you don't typically need to get it closed in adulthood for any reason other than recurrent endocarditis. So it's not generally so much of a problem that we need to deal with in the adult population. This just shows you where most of the VSDs are located. Most of them are perimembranous, which is right underneath the aortic valve. And one of the reasons why we don't have a device that's available in this country to close these defects is that I use this diagram. This is a Netter diagram, and it shows the conduction system. And again, the His bundle is intimately associated with the inferior margin of a ventricular septal defect in the perimembranous location. And one of the problems with the devices that we had is that they're made out of nitinol, and they exert this constant radial force, and they can damage the conduction system as a result. Now, you can say, okay, fine, but we have an incidence of heart block when we close these defects surgically. So that's true, except that you know about it right away. They come out of the operating room, they've got heart block, they've got epicardial pacing wires. If it doesn't recover, you put in a pacemaker. All right, fair enough. But the problem with these devices is that everything may look good, and they may have late heart block, Stokes Adams, and even death. And this has happened even several years out after perimembranous VSD closure with some of these devices. And so because of that, we don't like that to happen. And so really, we just have thought that this is probably not such a great idea. So most adults with congenital, have perimembranous VSDs. They have a small shunt, and we don't need to do anything about them. They're at risk for endocarditis, so they need to be followed and treated and known about that. So again, although we don't do anything in terms of prevention of endocarditis now with the changing guidelines, to know that patients are at risk for this and to do cultures and jump on it if they have positive cultures and to treat it appropriately is obviously important. I'm going to talk about some other case examples. I'm going to show an example of coarctation of the aorta. So 2 presentations, patients who were never diagnosed previously and those that were repaired surgically in childhood and then lost to follow-up with residual coarctation. This can lead to significant hypertension, coronary and carotid disease, LV systolic and diastolic dysfunction, and it can be associated with other left-sided heart disease as well. And the classic is that what you should have is an arm to leg blood pressure gradient. And so again, I'll just remind people that hypertension is obviously very common. You're going to see lots of patients with hypertension in your career. But young patients with hypertension who are refractory to medical management, those are actually less common. And so if you've got a patient who's not responding to your therapy, make sure that you do a blood pressure on their legs because you don't want to miss this. So the blood pressure in the leg should actually be higher, a little bit higher than the blood pressure in the arms. Certainly if it's lower, you should be thinking coarctation and get an appropriate imaging study. So I'll show you brief case examples. A 39-year-old woman who presented at 16 weeks gestation with respiratory distress. She actually needed intubation. Her echocardiogram showed severe left ventricular systolic dysfunction and diastolic dysfunction and a 30-millimeter gradient across the coarctation. Interestingly, she had a history of coarctation repaired surgically at age 9, but was followed by a cardiologist unfamiliar with the disease and cleared her for pregnancy with an EF of 40% 6 months prior. And so bottom line is that she had a significant coarctation. We catheterized her when she was 19 weeks pregnant, and we dilated and stented the coarctation and got the gradient down, and she did really pretty well. We managed her through the pregnancy on oral anticongestive regimen, and I put not an ACE inhibitor because it's teratogenic. We delivered her electively by cesarean section at 35 weeks, and she did well. And 4 months postpartum, we fully dilated that stent. We didn't go crazy right when she was pregnant because relaxant hormones and such, you're much more at risk for tearing the aorta and causing problems. So we waited until she was 4 months postpartum. And now 3 years postpartum, her EF has gotten better. She doesn't have residual gradient. She has persistent diastolic dysfunction, but has done well. I'm going to jump in and talk about another problem, pulmonary stenosis, and show a couple case examples. A 28-year-old woman who recently immigrated from Ecuador. She'd had a murmur her whole life. She's got some ankle edema, right ventricular hypertrophy on her ECG, and she's got severe right ventricular hypertension and severe valvar pulmonary stenosis. So this typically presents in infancy with a murmur. Any degree of pulmonary stenosis will give you quite a loud murmur because it's very close to your stethoscope. And mild stenoses will typically resolve in infancy, but moderate and severe typically need intervention. And the indication for intervention is typically a gradient of more than 30 millimeters of mercury. So this is a lateral angiogram. This is the right ventricle, the pulmonary valve, and you can see the poststenotic dilatation of the main pulmonary artery afterwards. This patient had an 80 millimeter gradient across the pulmonary valve. So this is actually pretty easy to treat. We just put a balloon across it, balloon dilate, pop, goes away. The gradient goes down right away, and these patients usually have some pulmonary regurgitation, but because of the low diastolic pressure in the pulmonary artery, it's usually not such a problem. So most of these patients who get transcatheter pulmonary valve dilations will not need surgical pulmonary valve replacement as they get older. So this is a slightly different take on that. This is a different patient, a 20-year-old woman with a history of pulmonary stenosis as an infant, and she had a surgical pulmonary valvuloplasty at age 3 months. So these will tend to lead to more pulmonary regurgitation. So this patient did have more pulmonary insufficiency, and she underwent a surgical pulmonary valve replacement with a bovine valve a year prior, but developed stenosis and regurgitation quickly, and she was very symptomatic. So this is, again, a lateral angiogram. You can see the regurgitation here. So there's a 45 millimeter gradient and severe pulmonary insufficiency. So what do we do with a patient like this? Well, first we have to get rid of the narrowing, so we'll put a stent there. Now, again, you can't just directly put a transcatheter valve in these patients because the right side is so much more compliant than the left side. Unlike the aortic valve where you do TAVR replacements, the aortic valve itself is very non-compliant, and typically in an adult where you're doing this in, it's calcified and you've got a nice ring in which to put something. On the right side, we don't have that because the right side is much more compliant, and so we typically need to create a landing zone with the stent first. So we go ahead and we put in this landing zone of a stent. And now we have this new technology, this transcatheter pulmonary valve replacement. So this was first developed in 2000 by Philip Bonhoeffer in Paris, and who reported the first man-in-man, where he took basically a bovine internal jugular vein valve and mounted it on a stent. And this work has been purchased by Medtronic. And HDE approval from the FDA was granted for this in December of 2010. And it was actually the first FDA-approved transcatheter valve even before the TAVR valves. And so again, this is this nice valve that's mounted there, and we mount it on this nice delivery system that has this covering over it. It comes in 3 sizes, 18, 20, and 22. So once we've got that stent in as a landing zone, we can go ahead and put in this Melody valve on the balloon. Just inflate the balloon there, and then afterwards we see that there's no regurgitation and no residual stenosis. So this patient is now asymptomatic and doing well. So these are some of the things that we do. And in 2019, we have availability of that valve and also the Edwards Sapien XT valve. So 2 generations ago, valve is now approved for the pulmonary position. Again, it's interesting that we don't, in patients in whom we need to use the Edwards valve because of the larger sizes, we're typically using the off-label newer generation, the S3 valve, and that's what most people are doing now, even though the older generation XT valve is the one that's approved. I'm just going to show you one selected structural heart example, some of the things that we do to treat adults with acquired heart disease with some of the tools that we use. So one of the examples is perivalvular regurgitation. So that's regurgitation that develops between the sewing ring of a prosthetic valve and the native annulus. It can occur around any valve, but the ones that we usually concern ourselves with are the mitral valve and to a smaller degree, the aortic valve. It typically presents as heart failure. About 10% of them will present with hemolysis. Surgical intervention in these patients is typically high risk. They often have multiple comorbidities, coronary bypass grafts, LV dysfunction, and these sorts of things. So this is a typical example. This is a 47-year-old with history of rheumatic fever, and he had aortic and mitral valve replacements with bioprosthetic valves. Most recently was 2 years prior. And he has progressive shortness of breath as New York Heart Association class 3. He's got moderate perivalvular mitral regurgitation and severe LV dysfunction. So I'm going to play this again. So again, this is the TE. This is the left ventricle, the left atrium. This is the bioprosthetic mitral valve. This is the left atrial appendage. And here you can see this jet of regurgitation next to the valve out near the appendage. And you can appreciate how poor his left ventricular function is just looking at that as well. So you can appreciate when we look at the 3D TE that this is really a crescent of regurgitation next to the valve. So I could just look at this forever. I love it. So I'm just going to keep playing it. So you see the valve in the middle. This thing up here is the atrial septum. This is the tricuspid here, the aortic here, and the leak is going to be over here. So what we do is we're going to come transseptal through there and go over to the leak. So that you can see our sheath has gone through there, and we have these steerable sheaths now that make it really easy. So here you can see this is the aortic valve. This is mitral valve. We have a wire through the leak, and then we can go ahead and put in an occluder. And all of these we're using off-label. In this instance, we used a 10 mm muscular VSD occluder. And we go ahead and we put that in, and we've got the one side on one side and the other side on the other side. And once that's in, you see that we've got a small amount of flow. So I'll tell you that a small amount of flow, it would seem that we've done a good job, but as we showed in this patient, his left atrial pressure decreased, but he was discharged, but he developed hemolysis, and he required some transfusions and things weren't going as well. So we actually brought him back and went ahead and crossed and put a second device in and completely eliminated the regurgitation. So this patient did well, and by 3 months, he was New York Heart Association class 1 to 2 with no hemolysis, and 6 years later now he's doing well. So I think as my time is up here, I had one other example of Fontan that I was maybe going to do, but I think we're going to leave it there, and I'll open it up for questions. Great, thanks very much.
That was really a wonderful talk, and it illustrates a number of things that most people in adult cardiology, adult medicine don't know. From a practical point of view, I think that what I've always done is palpated the radial and femoral artery pulses simultaneously. And that's, I think, much easier to do and will get done more often than measuring the blood pressure in the legs, which, as you noted, is the systolic pressure is normally higher in the lower extremities. And there were two patients, adult patients with coarctations, that were discovered at one of my institutions in 1 year by doing just that.
That's excellent. That's a good point. It's a really good technique to do. I'll say that even in patients who I know have coarctation, unless it's severe, you often won't necessarily notice a difference. Probably somebody who's got more clinical expertise than me, maybe even better than doing it. One of the things that will certainly accentuate that is if you get them to do jumping jacks and increase their cardiac output, you can often really accentuate the radial femoral delay. So the radial and femoral pulse should happen at the same time, basically, because they're about equidistant from the aortic valve. But again, if you've got a coarctation, that pulse wave will be delayed to the femoral, and you can certainly accentuate that. But you may not notice that difference unless there's a pretty significant coarctation. So the blood pressure will help you. It's always a bit of a paradox, like why is the blood pressure in the legs higher than the blood pressure in the arms? And everyone uses this term pulse amplification, which to me didn't make sense. But the way that I like to think about it is that when you talk about pressure in a fluid-filled system, that's the potential energy. But it doesn't take into account the kinetic energy, right? So the total energy of the system is the kinetic energy plus the potential energy. So again, the same thing, like, you know, if I've got my keys here, whatever, my USB sitting here, right? I've got potential, the potential energy is the height times the mass of this, right? Now I flick it off, okay, all my potential energy is lost, it's turned into kinetic energy as it falls, right? So that's the same thing. What happens is that you've got the kinetic energy is going out, but what happens is it gets to the periphery, it slows down, and that kinetic energy gets turned back into potential energy. So it's like rolling a ball down a hill and then coming back up. So that's what's happening is that as the blood slows down, it regains potential energy. And in a fluid-filled system, it regains that. We're measuring that as pressure. So like you would think, well, how is it that how can the pressure be higher downstream than upstream and still have the blood flow forward? like, what's this with this second law of thermodynamics, right? So it's still all accounted for. It's just that you haven't accounted for the kinetic energy. So the blood slows down and regains potential energy. The total energy is still the same. You've lost a little bit to friction and heat, but the total energy is still the same.
We have a question up now.
Yep.
So Carl Braun from the St. Luke's site. As a neurologist, obviously the discovery of the PFO in patients with cryptogenic stroke has given us tremendous opportunities and a lot of problems. I noticed you didn't mention the associated septal aneurysm in making the decision. I wonder if you'd comment on that. And the second is really the knotty problem of the patient with a cryptogenic stroke at age over 60 with a significant PFO.
Yeah, so I think that those are excellent questions. So the atrial septal aneurysm is that anatomy where septum primum is really very hypermobile, and what that allows for is for the door to be opened significantly. And so those, again, what that means is that I think it's just more that a substrate for the fact that can go across. Now, there are all kinds of PFOs and all sorts of anatomy. It's really very interesting, but there are the PFO where it's almost completely closed and you can barely get a wire across. You think you're going to get a clot to go across that? Probably not so likely. On the other hand, if you've got a septum that's very floppy and can go like this, yeah, something that's going through potentially has an easy opportunity to get from the right to the left. So I think atrial septal aneurysm definitely has been shown to be an increased risk factor for stroke in those patients. And there was a trial called the Defense PFO that looked at that specific anatomy and showed that closure of those defects actually had 100% risk reduction in terms of eliminating those. That was I believe that was a Korean study that came out recently. And so I think atrial septal aneurysm certainly is. So if you're kind of on the fence as to all these things, I often find the if they've got atrial septal aneurysm, that kind of nails it. And you bring up an excellent point about the age. So I actually just yesterday had a woman in my clinic who's 64 years of age with no other risk factors, who'd had a cryptogenic stroke, had an atrial septal aneurysm, and she's agonizing over what to do. And the neurologist at NYU had told her, you're going to see this guy I love. He's going to tell you to do it because he's an interventionalist. It's tough. It's true that we've studied patients less than 60 years of age because as you get older, all those other factors that lead to stroke become much more prevalent. So it would be very difficult to show a difference in patients that are older than 60. So this patient, though, is completely well. She has really no other risk factors. So I think that 64-year-old is more like the study population than some others. Now, again, you can have somebody who's 50 years of age, who's diabetic, hypertensive, hyperlipidemia. And if you think that closing their, then maybe they had a cryptogenic stroke and they've got a PFO and no atrial septal aneurysm. I think that my 64-year-old who's well and got an atrial septal aneurysm is probably more likely to benefit from PFO closure than this 50-year-old who's got all these other risk factors in terms of his recurrent stroke risk and prevention of disease. So I think it takes some finesse in terms of sort of figuring these things out. But definitely, the problem is that once you get to patients that are, let's say, in their 80s and such, all those other factors that lead to stroke in patients that are older far eclipse PFO. So, for instance, carotid disease or these sorts of things. Those things that are known stroke risk factors, those patients have an incidence of stroke of about 10% to 20% per year, as opposed to the 1% to 2% per year for PFO. So, an order of magnitude difference. So, closing the PFO probably, even if that was the mechanism, probably if that particular stroke, if a patient has another known stroke mechanism, is unlikely to affect their overall prognosis in terms of their stroke recurrence risk.
Yes, I'm always mystified by the difference between lacunar stroke and mild micro ischemic vascular disease. I see a lot of people who are 50 to 60 years old with multiple reasons for them to have atherosclerotic disease. And then they have some kind of event when they go to the emergency room, they get a CAT scan, MRI of their head, and you're faced with this, is this a lacunar stroke? Is this a microvascular or hyper hyperdensity thing. How easy is it to determine this? And because this is the crux of the matter with PFO.
So I think those are good questions. I'm going to punt because I'm not a neurologist, so it's easy for me because if the neurologist tells me they had a lacunar stroke and it's not due to PFO, I'm scot-free there. So I think it makes it easy from that standpoint. Obviously, this is a whole specialty of neurology in terms of helping us figure it out, and this is one of the things that's important. There was just a position paper that was published by the Society for Cardiac Angiography and Intervention that talks about this, and we've known this for a long time and stuff, but you really need to be pairing with stroke neurologists in terms of helping you figure out who the appropriate candidate is for PFO closure. Because as you point out, and as we've said before, PFO is present in 30% of the population, and so if you think that closing a PFO in somebody who's got stroke for other reason, it's not going to help. And not only is it not going to help, but I think that what's most important is that, for instance, that imaginary 50-year-old that I was talking about with diabetes and hypertension, hypercholesterol, if he thinks that you're decreasing his stroke risk by closing a PFO, and he's not actually aggressively managing all those other risk factors that are really the cause for the stroke or the major risk factors for future stroke, it's actually going to be a detriment to the patient rather than saying dude, you got to change your lifestyle and you have to be attentive to all these other things that you need to do medically.
So I was just, as a neurologist, I would simply refer you back to the original description of lacunar strokes by Miller Fisher back in the 1960s. And what he did was he identified first, I think, 3, and then it expanded to some 6 syndromes, and they were all characteristically isolated symptomatic. In other words, a pure motor stroke with absolutely no other findings, pure sensory stroke with no other findings, pure dysarthria with no other findings. So first of all is the presentation. And now with the MRI in the acute phase, it's fairly easy to separate out lacunar strokes from the more common microvascular changes.
Thank you very much.
Great. Thank you.